Okay, welcome everyone. Thank you for joining, for those online and for those here at Mission Hall. It's my pleasure to welcome you. My name is Jeremy Alberga from the Institute for Global Health Sciences. I'm the Director of Strategy and Program Development and one of the hosts of our visitors over the last couple of days. We're delighted to have you here. I'll do a couple of brief introductions of our speakers, and then we'll get into some slides, presentations, and of course, you are welcome to ask questions. For those of you here, we'll do Q&A verbally. If you have any questions, please feel free to add them in the chat. So just a very brief overview of our introduction of our two speakers. To my left here is Francis Kakooza, and he's the Deputy Head of Global Health Security Department at the Infectious Diseases Institute in Kampala at Makerere University. He is also a PhD candidate in molecular epi at Makerere, with a background training in biomedical laboratory science and international at the IDI in Kampala. And to my left is Agnes Kiragga, who's the head of the data science program at the Africa Population and Health Research Center, which sits in Nairobi, Kenya. And she previously worked as the head of statistics and data management at the Infectious Diseases Institute in Kampala. Welcome to you both. It's been wonderful to get to know you over the last couple of days. And one of the things that has been actually a bit of a surprise to me, or something that I didn't know, was that University of California, San Francisco has had quite an important role in setting up the Infectious Diseases Institute in Kampala. And I've asked Francis to say a couple of words about that. So welcome everyone, and without further ado, over to you, Francis and Agnes. Thank you for joining us.
So thank you so much, Jeremy, and it's a pleasure that myself and Agnes can share with you this talk on how we can leverage partnerships, innovation, and data science to strengthen global health security in Africa. But before I go into my presentation, I have a short story to share. If you look at the slides well, the Infectious Diseases Institute just celebrated 20 years of existence. And that was 2002 to 2022. And then we are aspiring for the next 20 years. And when you look at the slide, there are two images, which are very captivating to myself, and I hope they will be to you. So to the left is our latest headquarters at the Makerere University, main campus. But when you look at the right, it is actually our research lab, which at the celebration of 10 years, the UCSF contributed in its establishment, from the funding of the renovations to the equipping of that facility to, scientist placements. And it has generated a lot of research in immunology, pharmacokinetics, a lot of PhDs have channeled out that now serve as the senior scientists at the organization, and even myself, serving at the senior leadership. So I think the message here is that part of our visit is a thank you note to the UCSF. Because IDI making 20 years, the initial seed funding that came through Pfizer, UCSF had a lot of work setting up the program in research as part of the scientific advisory board and limit. So thank you so much, UCSF, and let me share with you how the Institute has really grown from looking at HIV primarily and expanding on that platform, consolidating it, but now going into global health security, not only in Uganda, but across the continent. So the Global Health Security Program is to support health systems in Africa to build their capabilities to prevent, detect, and respond. And this is a program that has been in existence from 2016, way before the COVID pandemic. And our three focus areas were laboratory, biosafety and biosecurity, epidemiology and informatics, then case management and medical countermeasures, including infection prevention and control. So I'll dive quickly into sharing with you the story of how we have managed to, to contribute to the health security space on the African continent, mainly through the different partnerships that we have managed to have, and also the different innovations that my colleague Agnes will go into the data science part. So as part of our initial setup was mainly working through, the US government, and the image there is the Ministry of Health in Uganda, together with the US ambassador, launching the National Action Plan for Health Security. And I think the plan here was, as we start setting up health security, can we have a clear-cut action plan that will guide on what should be done in the country to inform the health security programming? So this is now approved. It fits into the joint external evaluation, but also broadly, it's going to be, the benchmark on how we roll out health security technical systems in the continent. So furthermore, we have also partnered with the Resolve to Save Lives on the 717 Alliance, and this is mainly Tom Fraden and the team who have, set up the 717 Alliance in Uganda. And this is an alliance that really helps with timeliness framework for preparedness and response. This is a framework that we have rolled out in the different preparedness and response program, and recently with Ebola. And we have managed to use it as a benchmark on how countries on the African continent can be able, to identify, a threat in 7 days, confirm it and notify it 1 day, and set up a response program in 7 days that is very effective. So this has been piloted in Uganda, rolled out on the continent, and now we have been able to start writing on the lessons learned, share them out, across the continent. The next is on so that is mainly the story around our health policy legislation and setting up the national action plans that are going to inform the continent. Now, once we have finished setting up those policies and the plans, we have moved into now the real hardcore of the work. And part of the initial efforts have been on antimicrobial resistance. And here through, partnerships with the UK Fleming Fund country grant, we have managed to set up the national action plan for AMR. And this action plan is mainly to facilitate stewardship structures and also surveillance systems. And here, part of the work that we have managed to channel out is to roll out the WHO antimicrobial resistance surveillance system. And Uganda as a country has been the first on the African continent to have a fully structured AMR surveillance program that can be able to systematically collect the samples together with the metadata and inform some of the resistance pattern. And also have a huge biorepository of isolates that can be used for further genomic surveillance to look at, any, gene mutations and emerging variants that contribute to a lot of resistance that we see in specialized healthcare units. So on top of the huge biobank for some of these resistance isolates and metadata, we have also managed to set up a data integration and share. And this is a system that is housed at the Public Health Emergency Operations Center. So what is special about this system is that it brings together data from 3 line ministries. So we have the water and environment through the environmental water surveys, to active and passive surveillance in poultry, and then through also the Ministry of Health, mainly through the surveillance and samples collected from the human population. So it is both the surveillance for the resistance, but also surveillance on antimicrobial use. And all this data comes together in one central point where you can be able to do a lot of modeling and a lot of, prediction on what is going to happen in this sector. So that is the story around our antimicrobial resistance programming. So then the other area that we have also invested in is on the biosafety and biosecurity. And here in biosafety and biosecurity, it has been mainly on 2. 1, a biorisk management curriculum. And this is mainly looking at ensuring that healthcare workers have capacity to be able to handle, dangerous pathogens during public health emergencies. And also supporting the government of Uganda set up a national pathogen inventory where you can be able to map where, different, especially dangerous pathogens are. And that has led us to channel out some material how to establish a national inventory with dangerous pathogens, and also the training program on virus management. Recently, we have moved into a vaccine preventable diseases program, and this was mainly at the peak of the pandemic, where we received funding mainly through the US CDC, but also through the Resolve to Save Lives. And work here was to increase COVID-19 vaccination uptake among national prioritized communities. So we are the lead implementing partner for rolling out that program and ensuring that all key populations can be able to access, this vaccine. The second was to work with our National Drug Authority on pharmacovigilance. And here we set up a program with the National Drug Authority. And there was a mechanism of how citizens and the population in the country could be able to call in and also share any adverse events due to the vaccination, and also on data management. But also through this work, we have managed to receive more funding to scale up a life-based vaccination program, which is going to expand on the COVID vaccination, but also include other, platforms for measles and mpox. So through that work, we managed to go in for a very competitive grant through the MasterCard Foundation. And here we are partnering with Africa Union, Africa CDC on a program for research on vaccine effectiveness. So this program, we are partnering with the APHRC, and Agnes will be sharing, some of the work. But also, I really wanted to highlight that the UCSF is part of the consortium, where they are coming in on the implementation science program to ensure that capacities and capabilities for the National Institutes of Public Health in 15 African countries can have capacity to conduct research and outbreaks to inform in-country policy. So broadly under this work, where we are now an Africa CDC research partner, we have been able to develop a generic protocol for the whole African continent. And this protocol is being rolled out now in about 15 countries who are at different phases in implementation to look at the COVID vaccine effectiveness, to assess the impact of this pandemic on healthcare systems, looking at the key performance indicators. And also the countries where we are supporting them to set up a national biorepository for these, COVID-19 samples, which can inform future vaccination trials and programs, and also serve as a knowledge management hub, which is towards an academic consortium for health security in Africa, which is part of the, of the bigger visions we want to have UCSF and Africa CDC, where we can have research on the continent that can, inform some of the public health action. That is about the vaccine preventable diseases. Now, when we go into the laboratory systems, here the work has been mainly around accreditation, but also having facilities that can be able to conduct research in filoviruses during an outbreak. And here we have worked with the National Microbiology Referral Lab to get a College of American Pathologists accreditation. And this has really helped because in the recent Ebola outbreak, for the first time in Uganda, we had 2 labs that had capacity to do the testing and the confirmation of the virus, which wasn't the case previously. We had capacity to the Virus Research Institute. But also, we have managed to work with the Joint Mobile Emerging Disease Clinical Capability. This is the Henry Jackson Foundation, to set up laboratory capacity for high consequence pathogens. How can the laboratory and the clinical team work and conduct research when there is an outbreak? So this is a facility which is a center of excellence in the western part of Uganda that ensures that teams can have protocols ready, deploy them during an outbreak, and get familiar with how to work in an Ebola treatment unit and conduct research. And this is some of the publications that we have shared on our work. We have also done work around surveillance, and this is especially with rolling out the electronic integrated disease surveillance system. And this is something that we are doing in up to 85% of the healthcare facilities in the country. And here we are working with the different partners, including the Public Health Emergency Operations Center, WHO, CDC, to look at this program. And what has been the special ask from the ministries of health has been, how do we develop a disease outbreak monitoring center? Because a lot of the data is being generated through these patient data that is entered and alerts, but how do we put all this together and can be able to start profiling and predicting some of the outbreaks in the region, considering that we're in a hotspot for emerging, disease. As I come to, I think, the end of my slides, we have also moved into a bit of research on medical countermeasures, and yes, to establish innovative models for case management, diagnostics, and infection prevention and control. And part of the work here is mainly around what are the best models to apply, in an Ebola treatment unit, and what is the best infection prevention and control strategies, especially with the teams that keep conducting these drills, week in, week out to prepare for this moment. And also, looking at some of the validations, we have been involved in validations of the film array system and the global fever panel. And this is a clinical evaluation of the biofever global fever panel, which can look at a broad range of pathogens, within just a few microliters and get your result in less than an hour. And this is progressing to FDA approval as part of the validation that we have done. So I thank you so much for listening to me, and I'll hand over to my colleague Agnes to share with us on the data science aspects after my message around partnership.
Okay, thank you, Francis. So I'll tell you briefly about the Academic Center of Excellence in Bioinformatics and Data Intensive Sciences at the IDI. And this is an NIH-funded partnership that was founded in 2019. And the center is aimed at creating capacity in the use of high-performance computing, strengthening capacity around bioinformatics, data science, enhanced visualization capacities to support research and training that will really inform health in Africa. So the ACE, as I'll refer to it thereafter, really focuses on bioinformatics, data science modeling, HPCs, virtual reality, and really conducting work around research and training in Makerere University and the different partners that work with the IDI. So the ACE has been successful in training. To date, it has an accredited master's and PhD training program with the Makerere University that was accredited in 2019, and about close to 70 master students and 15 PhD students have been trained by the ACE. And we are doing a lot of work around African genomic medical training. The ACE is affiliated to the H3 Bionet Bioinformatics Center that is in South Africa. And there's a lot of capacity building through this partnership with different African countries in sub-Saharan Africa. And recently, the ACE has been accredited by the Africa CDC as a host institution for pathogen genomics training and fellowship that is going to host a couple of fellows at Makerere University. So there's a lot of capacity building going on, particularly around the African students, and just trying to see how we can increase capacity on the continent. With regards to infrastructure, there's some compute power, about 40, an HPC with 40 nodes, quite a big space with 32 gigabytes, and a lot of capacity that remains underutilized because of the need to use these facilities and capacity to harness the available resources to conduct high-level modeling. We do have an inverter that helps with the power surges, as is a very common occurrence in LMICs. And most importantly, the ACE actually partners with the Data Science Africa initiative through the Open Data Science platform, which is called ERAZI, that is providing space for high-level modeling in the continent. Then with regards to visualization, we are privileged to have one of few virtual reality labs in Africa, and this is just one of two other centers in the continent. And the ACE has really been at the forefront of, making 3D a reality, VR, and using these facilities in training African scholars around virtual training in COVID-19 infection prevention using VR, looking at how we can leverage these resources for training medical students around surgical procedures in trauma and obstetrics. So it's increasingly a very good resource within the Makerere University ecosystem and other universities in the continent. With regards to genomics research, we do have a lot of partnerships with researches going on in the African CDC through the PGI. This is the Pathogen Genomic Initiative. And we have one of our representatives, Dr. Gerard Boa, who is doing work around pathogen detection in children living with HIV and presenting with non-malarial febrile illnesses, looking at how to leverage advances around metagenomics. So we are excited to be in this space where we can learn and leverage the advances in metagenomics at UCSF. With regards to pandemic preparedness, and the S is also at the forefront, but getting its way around pandemic preparedness and using early warning signs to look at how we can leverage Africa-led data sources. If you look to the left, that is a poster that was using data from the community. These are community radio data using natural language processing to look at what the community was talking about COVID-19, the misinformation. We combined that with air quality data in Kampala, used mobility data in the city, and merged all this to see if we can predict and forecast COVID-19 during the pandemic. And then with regards to modeling the monkeypox, we also are starting to look at how this can be predicted during pandemics, and then use the data that is available in the research environment. And then these are some of our key publications that continue to grow, work around building capacity in bioinformatics and mentorship in LMICs, using VR for COVID-19, hand washing and base training in Uganda, air pollution and mobility patterns in Uganda and other cities, and how these affect transmission of COVID-19 and other respiratory infections. And again, one other use where we are looking at community practices of antimicrobials and how these were affected by the pandemic. So this is kind of the evidence that we're generating through the S and to contribute to pandemic preparedness. And then I'll now switch to my hat of the African Population Health Research Center. This is based in Nairobi, Kenya, where I head the data science program. It's based in Nairobi, in Kitsuru, and it's an African think tank that's registered in the US, but headquartered in Nairobi, Kenya, with a West African office in Senegal. To date, APHRC has a footprint in close to 35 of the African countries, doing work around research and research-related capacity strengthening initiatives. The staff base is mainly postdoc and PhD scholars, about 200, and most of these are coming from 15 African countries, with a few from the US and Spain. So the mission is really generate evidence, strengthen research and capacity in Africa, strengthen the R&D, and engage policy to inform action on health and development. And this is through a partnership model with the different scholars, the different projects in the rest of Africa, looking at impact tracking, knowledge management, and most importantly, policy engagement and communication as research is being conducted, as the last mile to research that is ongoing in the center. I'll just take you through the 4 program priorities for APHRC. The first is the health and well-being, where we're doing work around nutrition and food systems, sexual reproductive health, adolescent health, and child health, looking at chronic disease management, health system strengthening, and of recent emerging and re-emerging infections. Then we're also doing work around human development. This is early childhood development, youth transition to work, gender, education, and higher education research. And then the third is population dynamics, where we are looking really at migration and urbanization in Africa, urbanization and sustainability, water and sanitation, aging, determinants of fertility, and host the Nairobi Urban Health Demographic Surveillance, which is a slum, one of the biggest slum surveillance sites in Nairobi. And then to the right is the data science program, which I lead. And for this, we are trying to build federated platforms and systems that are going to support research. We're looking at the whole data governance in Africa. How are the frameworks? What what is available. There's a lot of data protection frameworks, and some countries have, some don't have. So looking at trying to harmonize some of these and working closely with Africa CDC, looking at the application of ML, machine learning and artificial intelligence and mathematical modeling, and of course building capacity in Africa around making data fair, harmonizing this data, and how we can use this to inform our population health in Africa. And then I'll talk about the INSPIRE network, which is housed under the data science program. So INSPIRE stands for Implementation Research for Sharing Population Information from Research Entities in Africa. It's a spin-off from the in-depth network, which was looking at data from surveillance sites, health demographic and surveillance sites in Africa. To date, INSPIRE has partners with close to 15 HDSS sites in 7 countries and 3 of the African Union regions. So for these, we have representatives of community data coming in from Francophone and Anglophone countries with an aim to build different INSPIRE nodes to coordinate work in the different AU regions. So the goal of the INSPIRE is to build a platform where we can use community health research to inform population health, make sure that we can create standards where these data are findable, accessible, interoperable, and reusable, leverage the advances around data analytics. And what is coming out of recent is the need to customize some of the data standards for African data. There are lots of standards out there, but if you're to harmonize this data for collaborative and pooled research, some of the data do not fit the internationally recognized standards. So we're taking the lead to customize this and create new vocabularies that will match the data that is generated in Africa. So the HDSS sites are contributing to estimates or looking at how we can quickly get estimates of the sustainable development goals, estimate the global burden of disease, and of course, increase health literacy from where the data are collected in the African communities. So I currently lead the INSPIRE network and we'll be happy to talk more about this. In terms of, sorry, yeah. Batteries. Okay, thank you. All right, so this is a slide again, just talking more about how we can leverage the INSPIRE network as a platform for conducting annual and targeted biannual surveys that can collect targeted information around non-communicable diseases, merging this with available health and demographic surveillance data to quickly merge this with big data and machine learning, combining this with climate, already existing Ministry of Health data in DHIS2, looking at different regional data sets that are coming out through large section productive health programs like the Countdown 2030. So we want to use these platforms to be to be a platform where we can use big data analytics to inform the continental and global indicators that feed into the Africa 2063 agenda, and most importantly, get quick insights around the sustainable development goals and human rights indicators in Africa. So that is the power of INSPIRE. And I'll just end the talk with a few of these ongoing projects. Sorry about that. A few of the ongoing projects that we are working on at APHRC through the data science program. So our initial funding came in through Wellcome Trust that was looking at creating an INSPIRE platform, an African-led platform where researchers can upload their data. What would the blueprint of this platform look like? And then we moved on to getting a grant from the APHRC in Canada to look at excess mortality in Africa due to COVID. And these data were harmonized from Kenya, Malawi, and Uganda, and seeing the impact of COVID-19 in Africa. And then the last, moving forward, we then have continued to develop this platform and seeing how best we can leverage technology, different aspects, the infrastructure that is out there to create a platform where we can use this for a lot of population health research. Then in 2021, we received a pitch project that is again harmonizing COVID-19 data in 3 or 4 African countries, again looking at modeling the impact of COVID-19 on health outcomes. We also are currently doing work around climate and health. We are combining remote sensor climate data with these population health records to look at longitudinal outcomes of severe and extreme weather and climate events on health outcomes in Africa. And then again, we have the PROOF project that joins APHRC and IDI to look at the impact of COVID-19 in the real world setting and how this is affecting the healthcare outcomes in the 15 African countries. So as a wind up, we have lessons learned. There's need for multidisciplinary data teams to support data science in Africa, capacity in the different data places where we collect data. We need to adapt to existing vocabularies, but also be wary of the fact that some of these data and vocabularies need to be tweaked to contain the data that is coming from Africa. And then leverage advances around creation of platforms that are interoperable that will be able to support data analytics in the African ecosystem. So I'll end with that slide and we'll be happy to take questions. Thank you so much.
Wow. Fantastic. Remarkable amount of work, and thank you so much for the excellent presentation, both of you. I think we have a small enough group. I believe we have about 25 folks online, and then we have about 10 or 12 of us here in the room that we can, if folks online want to ask questions, please unmute. You're welcome to put those in the chat too, if easier. And I would ask anyone who asks a question to just identify themselves, and maybe we could jump in with some Q&A. Anyone here in the room or online? Pam, please go ahead.
I'm fascinated by the HDSS and this linkage across many different HDSS sites. It's amazing. And was curious about sort of the status of linking that data to health outcome data in general. Like I'm sure, I have a niche interest in HIV. Someone else, I saw you had mental health on there, and I'm sure there's other outcome interests of others. How that works and how it's going. Yeah.
Yes, I think most of this has been the different questions that we attempt to address with the HDSS site through the Inspire are largely driven by the centers where the data are collected. So in some HDSS sites, you'll find, particularly the ones in Western Africa, are keen to look at the impact of climate on mental health. So for those centers, we then work with them to download the climate data, look at the coming in from the HMIS platform like DHIS2. We then again use that and see if we can come up with estimates. And this is all work that is ongoing.
Yeah. But
I think it's more of how do you generate the questions that benefit the HDSS sites, because many of the times they are looked at as annual surveys, the data remain unused, but we're trying to change that narrative and say you can use your data for evidence generation, get the results, and quickly make any impact within the communities where the data are collected.
Yeah, great, thank you.
Other questions? I'll jump in with a question just around data harmonization. It's not an expertise of mine, but I'm just curious, who's leading on this? Is this something that I heard you both represent two different institutions in Kenya and in Uganda. Are your respective organizations leading this, or are you expecting or seeing the Africa CDC leading on this, or is there a party that you're expecting or hope will lead in this in data harmonization?
So one of the things we've seen is the whole utilization of standards for data are really suboptimal in Africa. If you quickly go down to a Google search and look at the application of common data standards that some of which have been developed in the US for medical outcomes data, and how to fit this with the available data. It's probably just a couple of countries that have adopted standards. So we are leading the work, but working very closely with communities that have already embraced a lot of harmonization in the US, in Europe, and learning from their experiences to adapt this to the African data. And in doing this, realizing, okay, if we're looking at causes of death in Uganda, there's some causes of death that will not be available in international recognized standards. So you need to work and adapt some of these vocabularies. So it's best if it's African-led. We have a lot of support from Africa CDC in terms of how can we change some of these standards to fit the data that is coming in the continent. So we are taking the lead, but working with the other partners. There's an African chapter on harmonization. So we log into that, and it's a whole community of practice.
That sits within the Africa CDC?
And that sits within, so no, it's not within the Africa CDC. We have an African chapter that leverages the different, but there are European chapters in Spain, chapters in the US that are already taking lead in harmonization. So we just tap into that experience.
Great, thank you. Other questions? Robert, are there folks online any questions in the chat? Okay.
I have a question about the data you're generating. Who so far are the users of the data that you're generating? So do you have either the European Union or users in Europe, or do you have Americans that are tapping into the data and finding it useful for their research purposes at this point, or not yet, or who are the users?
Certainly, if you are working with global partners, it's a win-win, because some of the projects are funded by global partners, and there's interest from those the funders. But what we're doing a lot is to co-design the projects in a manner that the data is best used and the findings are adapted where the data are collected. So I would say it's 50-50, but you're trying to get that to 60-40 so that you get the outputs that best benefit the community from where the data are produced. And there's a lot of literature out there around the whole iceberg of data sharing in Africa, where you find some, researchers from the global north will fund the data and have it analyzed in the global north. But we are trying to change the narrative and say there's a lot of capacity through partnerships with UCSF, CZIID, QBI, to help us build that capacity on the continent. So the users should be the data where it's produced, but again, for global health research, we have to work with them. Thank you.
I can maybe add something to what she has just shared. I think broadly, the agenda is led by Africa CDC. That is, it's Africa CDC broadly leading the agenda. And in this sense, what we have done has been in different phases. So the first thing, because if you look at the whole data standardization and data sharing, where do you start and how do you make it structured? Because there will be so many parts of there's data sharing, there's data fairness and all this. But broadly, what we have done with Africa CDC is to look at it from generic research protocol. And I think this is something that has not previously happened, especially during public health emergency. So what now we have is that there is a generic research protocol which has been developed by IDI and the partners, approved by Africa CDC, that is this intelligence and surveillance division. And then it has been sent to these national institutes of public health. I think that's the first step to ensure that there is standardization, because the biggest problem we have with mainly the health security data is that the parameters are different that are being measured. So if you want to look at it at a continental level to measure like impact or to understand, you can't. Because one person is picking up this information, another one is saying this information, then it doesn't really make sense if you really want to look at it. So I think that has been one of the key things, that a generic protocol
that is approved by Africa CDC, and then it is deployed in the countries, and then the countries, all they have to do is to customize it for the parts of the local context. That's one. Then in practicality, the second thing about data ownership, that's a whole big discussion. But I think the biggest important issue is who uses the data. Because it can be owned by anybody, but the most important thing is also the use. And here is that we have also designed a model where the ministries of health are the principal investigators. And it has not really been the narrative for research, because usually you have like a university, and the challenge we have like in Uganda or abroad is many African countries is that there is that the knowledge generators are very far off from the knowledge users. So now what we have done is that let the principal investigator be the ministry, like the director of the institute, so that they can own the data, but most importantly, use the data. Because that's the what is most important. Because you can own it, but if you don't use it, it doesn't make sense. It doesn't, you can have the data, you're rich with data, but poor with information. So now what we're trying to push is that let the PIs who are sit at the ministry and our ministry, and the university is only coming in to give technical support. So that is now the other part of like the PI is at the ministry, the co-PI is the university in those countries. So what IDI together with UCSF and APHRC, they come in as technical assistants. And like for example, them coming in to support the data, IDI comes in with the whole research management. UCSF is coming in on the implementation science, and that. Then the third part is on the data harmonization and systems. So again, what we have done in this COVID vaccination program is to ensure that there is a data management system house that Africa. And this is through a Red Cup platform. And this is hosted at Africa CDC, but each of these countries have access to their own data. Because also at the end of the day, Africa CDC now with its autonomy to like declare public health emergencies, they can't do much if they don't have like a data-driven center, which like can technically inform the decisions they're gonna make. So that way it builds capacity to the African Union, but also countries have the ability to access their own data and inform their own local decisions.
Right.
But also this aggregated data can inform Africa CDC. For example, things around like the impact of the pandemic on care systems, maternal health, HIV, malaria, So I think with this Africa-wide vaccination program, and where IDI, UCSF, and PhRC are working, it's mainly to ensure that one, there is the data ownership, but also most importantly, the data use. And because ownership can be there, but again, if you're not using the data, I don't think you're a very good owner. Yeah, it's and also to the translation of the data into information to be able to inform. Now, the other part that you talked about, the use, which is again a very good question that you said, who owns this and who uses it? It's also to look at it from what I mentioned, the academic consortium. So what Africa CDC, we're starting to work with is they're setting up an academic consortium for health security in Africa. So this is mainly through the initial funding of MasterCard, but they have tasked IDI together with partners to develop this program. So I think last evening they had given us at least the first level of approval, but we're trying to respond to their comments to see how it's aligned to part of the values. But why I tell this to the UCSF is the bigger vision of the Africa CDC is how can partners work together to have research during public health emergencies? Two, how can we be able to have pre-positioned protocols? I keep telling, I give you an example of my institute is that by the time we put in a protocol for some of the, the Zima for Ebola, the outbreak was coming to an end. the time we started publishing the protocol for the follow-up of the Ebola survivors, to look at the outcomes. The follow-up period was literally like 30 to 45 days into it. So what it's looking at is how do you have positioned, research protocols that are developed, which we can work on IDI and CDC and UCSF, and these are approved by countries. And then once there is an outbreak, they already have them in place to roll out because you already know what is expected. Like you have to do serial surveillance, you have to do this. So these, one can think they're a bit far-fetched from the data use, but I think that is the practicality. Because again, if you are rich with data but poor with information, then it doesn't really help. So with so many ideas on how to, make best use of data, access to data.
Thank you. I have one quick question. This is to you, Agnes. About the data, sorry, my name is Eva and I work with the GSI group. I had a question with the data center. Where is that? Is that in Nairobi or is it in Uganda? The data center picture you showed earlier in the slides.
The African Center for that is housed at the Infectious Diseases Institute in Makerere.
In Makerere. And quick question, I know there's challenges with having a physical data center and things like that. How this maybe, and it's okay if there's no answer to this question, because having a physical center has its challenges, given all the things with power problems and things like that. Is there any plan to pivot that to the cloud? What does that look like? Or is that a plan for the future?
I think there is, you raise very important questions. As you know, power outages, LMICs, I would say, LMICs are a challenge. But at the ACE, there is a standby inverter that has an alert system that will inform the administrator of any surges, and the need to back up frequently is one of the things that we are keen to do. But I agree that at some point you need both an in-person, a physical, and the cloud storage, largely because the latter, as you know, cloud storage is costly, and all these virtual machines, and it needs a lot of resources. So the NIH offered the hardware, and as a start, and as we build capacity and get more resources through partnerships and grants, we can then have a hybrid where some services are through a cloud-based platform, and leveraging the advances from CZID, we can see how to set this up in-house, and
Okay.
But maybe I can also add to what Agnes just mentioned. I think also the other thing that we are looking at, maybe the cost of entry, you raise something very important. What are the new technological advances to running data science? I think some of the slides I shared earlier on was how do we establish an exchange program? Establish an exchange program because the infrastructure is there. You know how technology just keeps changing all the time. Today you think this is the best technology. Next time it's totally not the best. So I think broadly, how do we establish that exchange program for knowledge management, for knowledge sharing, whereby you can have like placements, UCSF can come down to Uganda, set up these systems and with the technology, transfer knowledge, be part of the new innovations in modeling, but also we can have, a similar thing where, faculty can come here. I think for me that is the broader or the longer term solution to some of the challenges sustaining some of it.
I think you came to the right place. Even some of the people on this table are. But this has been what a wonderful presentation, and I actually one of my questions was going to be to you. How can we help? But I mean, I think you've laid out in the answer to that last to Jacqueline's question and Tiva's question some of the ways that we can partner with you. I do want to thank you first of all to those online. If you have questions or would like to talk further with Francis and Agnes this week or in the future, please reach out to me. They're here till Friday. Please reach out to me, Jeremy Alberga, or Susie Welty, and we can connect you. For folks here in the room, I think we can stick around for a few minutes and answer any further questions. Lastly, please join me in thanking again Francis and Agnes for their presentation. Thank you for having us.
Thank you.